Okay, shall we get started? I think every people are in. Welcome, everyone. And I think, Kelsey, we can take off the slide for a second. Thank you. Welcome, everyone, to our discussion on the ethics of uncontested intimate exams. We have a really great event today, I think, and I'm looking forward to it. But I wanted to first start off with a couple housekeeping things. I wanted to let you know that we will be accepting questions through the question and answer box, which should be in here down there. So if you put in your questions, we will try to get to them all as we can. So feel free to put them in during the presentations. Also, this will be recorded. It is being recorded. It will be up later this week. And if you registered, you'll have it. You'll get a notice. If not, come and look on our website and we'll be able to find it for you. My name is Lucy Nolan. I am moderating this. I'm the Director of Policy and Public Relations here at the Connecticut Alliance to End Sexual Violence. So why are we here today? There's a longstanding practice in some teaching hospitals that allow medical students to practice intimate exams, pelvic and prostate exams on patients while they're under deep anesthesia or unconscious for an unrelated, then the exams are unrelated to the medical procedure. The implied consent signed by the patient may state that the students may be involved in observing and providing care unless you disagree, but does not cover an intimate exam. Not only can this be an issue for the patient, but also for the medical students who prefer to get the patient's permission prior to the exam. Kelsey, can you put up the other slide, please? So this is a slide of what's been going on in the country. And 2019 is the first year that Connecticut put in legislation. There was legislation put in to require explicit consent for these types of exams. And as you can see, there were 4 states in 2019. And since then, there's been a large number of states, 19 that have passed laws requiring explicit consent for exams. And these laws generally end the practice of medical students performing extrapelvic or prostate training exams on patients under anesthesia unless the patients are asked in advance and agree to participate. So here in Connecticut, a similar bill has been raised each year over the last 3 years, but the bill has never made it out of committee. 1 year was because of COVID and the legislature closed down. But last year, we did not get a public hearing, yet 20 legislators introduced the bill led by Christine Cohen from Groton. And it was also co-sponsored by 18 legislators. So we know that there is support for the bill. And that's why we're here today, because it's likely to be raised again. We gather here today to learn more about the issue, and we're delighted to welcome ethicists Art Caplan and OBGYN Julie Chor here to speak on the medical and ethical practices of doing these uncontested exams. And I just want to start with Dr. Caplan, and thank you very much for joining us today. He's also, for those of us who live in Connecticut, a Connecticut resident, which is just great for us. Thank you. He's the Dr. William F. and Virginia Conley Mitty Professor of Bioethics at New York University Grossman School of Medicine, and also the founding director of the Division of Medical Ethics. And we asked him here today because what he is able to do is really discuss these issues of medical ethics in a way that intersects science and one would even say a little bit of culture, for those of us who are not scientists, to understand it. And so we're very pleased to have you here today. Thank you, Dr. Caplan.
Thank you. Can you hear me okay?
Yes.
Very good. Well, thanks for having me. Saying hello today from Richfield, where I am in Connecticut. I want to make a number of points about the need for legislation in this area. The first point is that I'm very sorry that we need this legislation. There is no ethical argument for unconsenting examinations of men and women, intimate exams of the reproductive organs or other parts of the body that have special cultural status and value as private and intimate. None, zero. The fact that people want to teach how to do a pelvic exam or might want someone to be able to look for anal cancer or have some interest in some other training of medical students, nursing students, dental students, whoever, never should excuse morally the use of people without their permission. It's not even complicated. The second point, I serve on the NCAA Sports and Ethics Committee. Some of you know in the headlines, we have been chasing down physicians who undertook exams of athletes, students, people in their care, gymnasts in Michigan, performing all sorts of unconsenting, undescribed examinations upon these people. A number of them have been sent to jail. They are sexual predators. I'm not saying that people who want to undertake training for a student is a sexual predator, but I am saying the distance between what we've been trying to weed out in terms of abuse in the name of physical examination by physicians with athletes and unconsenting examination of women and men for intimate exams is not as big as I'm comfortable with describing. It is a cousin issue when we are outraged that people have misused their authority with athletes. Then I think we should be equally outraged if that authority, even for a higher purpose, teaching, training, is still misused in terms of getting permission and consent. Third point, many of the people involved in these exams, whether it's athletes who are in a power relationship differential with the doctors and their coaches and the culture of team sports, or women in a prison who may undergo these examinations, or women in teaching hospitals. For those of you who don't know, many teaching hospitals, like the one I work at, see large numbers of poor women and men, and they are, and I keep emphasizing women because I think the problem is bigger there than it is with men, but it does cover both. But we run Bellevue. We have lots of prisoners coming in. We have lots of women who have no choice about where they get their care at NYU. These are not people who would be thinking, oh, well, I'm in here, I'm probably going to be used for teaching purposes or demonstration purposes. There absolutely is a class issue. When I have gone into NYU for medical care for various things, everybody makes a point of asking me if I mind having students come by and watch whatever it is that's going to be done, or scrub in or sit in. And as it happens, I don't, but I do like getting asked. I do think that's a fundamental requirement, and that lets me move on to the next point. Why? Well, it isn't just to prevent harm or injury, it's a sign of respect. It's a sign of dignity that you don't touch people without their permission. You don't examine anything about them, including intimate areas, without informing them and getting their permission. It's basic respect. And I think the reason this practice went on so long is many of the people were female, and they didn't get the same respect in terms of having choices as might have been shown to me when I went, or when I go to the hospital and someone says, do you mind if we have people sit in and learn how to do a history or learn about a procedure by sitting in with you? I know when I was around medical school some many years ago, we were also doing things like practicing on a cadaver, how to intubate and things like that. And I found that offensive, and that was on a dead person. But the reason is families have a right to control the disposition of their relatives' bodies. And again, in our Western culture, a deep sign of respect for the dignity of the individual, the rights of the individual, is to control their person and their body No one touches you. No one has a right to do anything to your body, even in the name of a high purpose, like teaching about medicine, without your permission. We don't have a lawyer on our panel today, but there is a term for unconsented touching, and it's battery. And I have been involved again in a case or two where physicians did molest someone who was unconscious, got sexual pleasure out of it, and again, wound up losing their licenses and in one instance, serving jail time. It's not a minor offense to interfere with, manipulate, touch intimate body parts for purposes that have little to do, if you will, with therapy and potentially something to do with teaching. But people don't go to hospitals to teach, to become learning subjects. They go there to get therapy, which is the next point. Many of them will give us the gift of saying yes, if we only ask. It's not like people are there saying, well, you know, I'm absolutely never going to let anybody learn anything. I don't want anybody to try anything for the first time or do something when I'm under anesthesia or whatever. I think if we make it part of our general practice, we can get permission to do these things with individuals. You have on with you today, some of you may have heard about these pig heart transplants. We've done some at NYU and a few other places in the US have done them with kidneys. I'm the guy who said, maybe we could learn by practicing these procedures on newly dead people. I put forward a model that said, let's put the pig heart into someone who's died but is still on supportive machines in order to learn. But what I did not say was, let's do that without permission. We have to have consent before we would arrange such a model. You've seen these experiments in the news of trying something on a newly dead but maintained artificially body, and people do volunteer to let us study. They sign their donor cards and say, I want it to be in research, and if you can't use my organs for transplant, then study me. Or family members or both will say, I give you permission to do this. So there are many areas of medicine, research, teaching, training, where we have to make sure that patients trust us. The biggest problem, and I'll end with this, that we've had in COVID is trust. Again and again, we see many areas where patients say, I don't trust the doctor, I don't trust their advice, I'm not sure they're telling me the truth, whatever. Distrust is a major hindrance to beating back COVID. The way you build trust is to be transparent. The way you build trust is to view your patient as your partner. As I said at the beginning of my remarks, I wish we didn't have to have a law. I wish it was ethically clear, understood that no one does anything to anybody else without transparency, full information, and prior consent. But sadly, that isn't always the case. As other states have done, I think we should join them in Connecticut and make sure that it is clear in law that all examinations, intimate examinations, be done with the prior consent of the individual.
Thank you very much, Dr. Caplan. That was, there's a lot to unpack there. So thank you. I appreciate it. We did have a question here, and there's a couple questions, but one was, I work for a hospital system that has hospitals across multiple states. What course of action do you recommend taking to eliminating uncontested intimate exams at these facilities? Is it a policy that we can set at our hospitals or something that needs to be tackled at the state level?
Yeah, both can be done. I would urge that trustees be presented with the decision to establish policies for the system. I would urge that education go on within the member hospitals and institutions of any system about what's required, who you report to if consent does not appear to have been obtained, and how that's going to be handled. Systems can absolutely move this forward. They should. As I said, there are many other settings, institutional settings, prison settings, other places where I still think we're going to need Connecticut to act, other states to act. But yes, you absolutely can bring it to the attention of trustees and make it part of the system policies.
Thank you. And then there is a second part to this question, which I want to answer a little bit before you do perhaps, but well, actually I may answer it all completely. The question was the person who asked the question formerly worked as a victim advocate in the emergency department and was uncomfortable with unconsented, sane or safe exams, sexual assault kits. Can you speak to the nuances of why these exams are allowed or deemed by some as more ethical despite not being medically necessary? And I just want to answer that an exam in Connecticut, you have to have explicit consent from the person who is getting the exam done. It is not done. I just want to put that out there, that if you say no, you don't want an exam, or if in the middle of the exam, a patient says or victim says no, they don't want to do it, the exam stops.
So I just had a meeting. I'm an advisor to New York City's SAFE group. We basically have the same arrangement. The only exceptions that might be allowed is if someone were so physically disabled, we might take a injured harm from a family member or partner or something like that, where consent would not be possible for many days, weeks, or maybe ever again if they're really badly hurt. Outside of that, I agree.
Yeah. And then are patients able to say that they're not willing to consent for this type of exam?
Sure, they absolutely can. They have that right. They're under no obligation or duty to do that if they don't wish to do it. But my belief is if we start to make it routine, the requests, if we start to ask and say, look, this will benefit what your children will be able to get from medicine because we're training the next generation, I think you'll see it. There's also always the opportunity of hiring people to be the subject of examinations.
Yeah, and I think we'll hear more about that from Dr. Chor, but I do want to say, I think one of the things that you brought up earlier about when you, Dr. Caplan, go in to the doctors and they ask if a student can come, I'm sure, in along and watch what's happening. There was a time when that was never even asked, that students would come into the room and just participate in an exam without any, and the patient would just do it because that is sort of what our medical system was like many years ago, but it's evolving like the rest of us. And so I think that this part.
Well, that's true. And remember, I am so ancient and old that I remember when we didn't even tell people the diagnosis, that the doctor said, you don't need to know, they don't need to know, we'll just treat them for whatever it is. If it's serious, we don't want to scare them, we don't want to frighten them, we're not going to use the word cancer, we're not going to use any dire prognosis. We've changed, and that's an improvement. I can say I have been myself present way back in the day when people were subjected to research without them understanding that it wasn't therapeutic, that somebody was studying something. So these don't make it right. They just make it the object of history as to why did it take so long to change.
Yeah, and I think that's a very important distinction here for this legislation as well, that it doesn't necessarily make it right, but it's time perhaps that it changes. And then quickly before we get to Dr. Chor, I just wanted to, one of the things that I found interesting when you talked about your work with the NCAA and the student and the athletes and the sexual abuse that many of them we've seen over the years. And I mean, just incredible what happened in Michigan. And sort of comparing the two, and in many ways, I think that's why we're involved in this as well. We see this as a it's a very close relation to having somebody being touched without their permission. And
in many instances, a Michigan situation, you see young women really feeling they don't have a choice about what's going to be done to them, or believing that what is being done to them would never be done unless it was necessary medically.
Right.
They trust what's going on around them, and we can't betray that trust.
Yeah, thank you. And I agree with that. Okay. So I would like to introduce Dr. Chor, who is going to speak about, and one of the other sort of burning questions on this is if somebody does get asked, would they in fact authorize this? And so like Dr. Chor, she's a OBGYN who specializes in patient-centered gynecological and reproductive health care for adolescents and young adults. And she has a clinical medical ethics training and concentrates on her academic research on medical ethics, patient-centered care provision, and trauma-responsive care for adolescents and adults. And she will be presenting today on a study offering explicit and informed consent to patients while undergoing pelvic exams under deep anesthesia. So Dr. Chor, thank you so much for joining us today.
Hi, thank you so much for inviting me to give this talk. It is, I have to say, also an honor to share the metaphorical stage with Dr. Caplan. So this is a real treat for me. Yes, I'm going to be presenting on the topic of pelvic examinations under anesthesia, or EUA, with learners. As a gynecologist, really my area of focus is on the pelvic examination, but a lot of this, as has previously been stated, extends to other intimate exams. Next slide, please. I have no conflicts of interest here. So just to get kind of at the scope of the issue of examinations under anesthesia with learners. Next. This is a common practice, and there's some older data to demonstrate that. A survey of 400 medical students from 5 medical schools, sorry, there was a typo, participated in exams under anesthesia. Of those 400, 90% reported having participated in these exams. Go ahead. Obtaining consents for students, however, to perform these examinations is not common. So it's a common practice to participate. It's not a common practice to obtain explicit consent. Of those students surveyed, about 3/4 had reported that they did not believe that explicit consent had been obtained from the surgical team prior to their participation in examinations under anesthesia. Next slide, please. A more recent survey from Elle magazine. It's kind of interesting. There's not much information, unfortunately, in this article about methodology, but just to say that the numbers are quite similar. So this was a survey of students at 7 major medical schools. About 100 students were included, and the statistics really continue to tell the similar story. So 61% of students in the survey reported that they had participated in an examination under anesthesia without explicit consent. About 50% of them reported that they had not met the female patient before conducting the pelvic examination. And also nearly 50% of students who'd done a pelvic examination under anesthesia without consent were uncomfortable with how the schools had handled these examinations. One thing I just wanted to say, in addition to the information that was presented from my bio, medical education is also a large part of my job. I'm the assistant clerkship director at the University of Chicago, and I teach quite a bit, including one of the co-directors of our medical ethics course at the university. So this is something that is very near and dear to my heart in terms of interactions and how this impacts students. Next slide, please. This topic of examination under anesthesia with learners is something that is not new. This topic comes up, I would say, maybe every 5 to 10 years, actually, in the public discourse as well. This is an article from about 2 years ago in the New York Times Magazine, and was a pretty deep dive into the topic of examinations under anesthesia without consent. Next slide, please. So looking at the patient perspective, we have some data on prevalence of this practice and how do patients feel about it. Some surveys looked at patient sentiments about having had an examination under anesthesia without consent, and 72 to 100% of respondents in these surveys reported that they felt that they would want explicit consent, and that the majority of them felt that the practice of having this exam without consent was equivalent to assault or battery, as Dr. Caplan mentioned. And rightfully so, and I think that that translates to how the law interprets this as well. The topic of exams under anesthesia also has been really brought into the fold under the Me Too movement. And there's a Twitter hashtag, #MeTooPelvic. And if you look for that, you'll find stories of individuals who underwent exams under anesthesia without consenting for those exams. Next slide, please. So what about the student perspective? I can tell you, I hear it from students when they experience being in the operating room and they're uncertain if consent was obtained. And it's certainly this practice in terms of the perspective of the student is absolutely met by significant moral distress. Next slide. This is another kind of more public discussion of this topic from This American Life on NPR, a popular show that probably many in this audience are listeners of. This was from several years ago, where the topic of, this was from the perspective of medical students who described their experiences participating in exams under anesthesia. So one of the participants, one of the students reported, oh yeah, I think it's horrifying. Absolutely. I think that what's wrong with me? Why didn't it occur to me that I hadn't actually met this woman before? And it never occurred to me. I think it's pretty horrible. Yeah, it's one of those dirty little secrets in medicine. So this was, just to give you a little context, this reporting and this storytelling was several years after these events. And so these experiences linger with learners. It's not just at the time of, but people tend to come back and think about these events and feel pretty uncomfortable with their participation. Next slide, please. So an interesting study demonstrated that actually students' perspectives on their participation in pelvic exam under anesthesia without consent, or with or without consent, changed as they went through their OBGYN rotation. And so you can see, please advance, please. For those individuals who haven't gone through their clerkship in obstetrics and gynecology, so where they spend 4 to 8 weeks on the rotation, get exposure to all aspects of obstetrics and gynecology, the vast majority of those students who were surveyed before going through their rotation felt that getting explicit consent was either somewhat or very important. However, for those who had subsequently gone through their rotation, advance please, that number actually dropped. And I do think that there is some kind of numbing that can happen. And this is another important reason why obtaining consent explicitly and for students to be a part of that process is so important, because there is a, as I said, kind of a numbing or a loss of perspective as they're exposed to this practice of performing exams under anesthesia without explicit consent, such that they start to normalize that practice. Advance, please. Factors that were associated with finding that consent was important: female students were much more likely to feel that obtaining explicit consent for an examination under anesthesia was essential. Next slide, please. So the legal and professional perspectives, as was stated previously, many states at this time have laws on the books that mandate explicit consent at the time of pelvic examination under anesthesia, and it can be considered a misdemeanor. This can be grounds for loss of medical license, and my state of Illinois was one of those first states to have such a law. Next slide, please. Looking at the professional societies, the American College of Obstetricians and Gynecologists has very clear statements about the importance of obtaining explicit consent. And they say pelvic examinations on an anesthetized woman performed solely for teaching purposes should be performed only with her specific informed consent obtained before her surgery. Next slide, please. This statement is from the Association of Professors of Gynecology and Obstetrics. So they're the governing body for medical education in the field of obstetrics and gynecology, and they really support ACOG's position. So they say OB-GYNs must go above and beyond in our efforts to preserve the trust, as was mentioned by Dr. Caplan, that is central to our relationships with individual patients and with society at large. Institutions should develop, implement, and monitor processes to ensure transparency regarding pelvic examinations under anesthesia. Physicians should support and comply with these processes in our interactions with patients and with learners. The trust of our patients and the safety of our learners depend on it. Next slide, please. So from looking at kind of more principles, fundamental principles of clinical medical ethics, this practice of examination under anesthesia with learners without explicit consent violates core principles of autonomy, basic rights to bodily integrity, and trust. This results, as I've demonstrated or pulled some quotes to show you, this results in moral distress for learners. There are significant professional and legal implications of continuing this practice. So why is this practice continuing? Next slide, please. So here are some proposed defenses of not seeking explicit consent. One is the concept of the implied consent. When obtaining care at a teaching hospital, one is automatically consenting to having learners involved in all aspects of their care. Secondly, a therapeutic involvement. When the patient consents for any surgery, there's often kind of a generic statement about learners being involved in those procedures. And so the thought is that this really is in fact consenting for an intimate exam at the time of their surgery. Another argument is the concept of the slippery slope. Well, if we have to ask for consent for this, do we have to ask for consent for every single aspect of student involvement, no matter how big or how small? Next slide. And additionally, this concern that there would be decreased opportunities for students to learn the pelvic examination if we had to explicitly ask permission of patients. And I have to say that all of these arguments to me are troubling, but I would say that the fourth argument to me is the most troublesome. Really, if people are not asking for consent because they're concerned that their patient may not agree to providing consent, then that is a real problem, right? Next slide, please. So as I said, in Illinois, the need to consent for pelvic examinations under anesthesia has been longstanding. We introduced a kind of a more formal protocol for this process in the family planning clinic that I work at the University of Chicago. And so all patients obtaining surgical abortion under anesthesia we had pre-printed forms for consents. And on that form, in addition to the other procedures, it was explicitly stated exam under anesthesia, including trainees. We also had a kind of in the electronic medical record, an automatic embedded way to communicate to each other whether or not the patient had agreed to providing explicit consent for examination under anesthesia with learners. So this was introduced several years ago. So research is in my veins. And so, of course, with the introduction of this new protocol in a much more kind of standardized manner, knowing these arguments that are in existence that have been used to push back on obtaining explicit consent, I was very eager to look at what our numbers demonstrated. And so we conducted a chart review for a year's worth of charts. looking at factors associated with accepting or declining pelvic examination under anesthesia with learners. And really the most important piece of data that I wanted to solidify was what percentage of our patients would or would not accept an examination under anesthesia with learners. And as Dr. Caplan anticipated, our data really supports that most patients, when you explain why this is of value, explain the role of the student and how this may be beneficial to them, most patients agree. So nearly 90% of our patients were accepting of having learners participate in this aspect of their care. Next slide, please. Factors associated with accepting versus declining. Again, this is a relatively small sample size, so these data are a little bit less useful than the overall 90% number, but presence or absence of support in their decision-making, contraceptive choices, history of intimate partner violence, approach significance, and desiring different protocols with the remains. These were related to accepting or declining. But again, I think that to me, the most important single piece of information here is that 90% of our patients were accepting of having students involved in pelvic examinations at the time of anesthesia. Next paragraph, or next slide, please. So in addition to conducting a chart review for more quantitative data, I really wanted to understand the perspective of healthcare providers in introducing this more formalized protocol. Again, trying to understand, were physicians and healthcare providers going to experience any challenges with this? And were they perceiving resistance from patients, or what, were there any challenges in this process? So we performed interviews with resident physicians, fellow physicians, and attending, so supervising physicians, exploring the experiences consenting for examination under anesthesia with learners. We used the kind of best practices for qualitative research. Next slide, please. And our findings were, we interviewed 15. We actually have 4 more who also participated in interviews, but the findings are very consistent, and looked at provider experiences and reflections, centering the patient and the role of learners. These are themes that came up. So looking at providers and how they feel. Next slide, please. There was some initial apprehension that patients would decline. So again, not unexpected. I think once I thought about it a little more, it sounds like more work, and I got anxious that patients would not be receptive to having providers, especially medical students, doing an exam under anesthesia. Then I realized that's the whole point of adding the consent, is that some people are not comfortable with having medical students do an exam under anesthesia. There was unanimous support for integrating a formal protocol into this process. I actually really like that it's on the consent. I was like, this seems like a really kind of structured, reasonable way to make sure we have this conversation with every patient. Advance, please. And the importance of phrasing this discussion was highlighted. I think the biggest concern that I have is making sure that I word it eloquently enough where it doesn't feel like we're putting the patient at increased risk by having learners involved, or making the patient uncomfortable for more people being in the room or involved in their care, and just wording in a way that we're learning, we're training. This is an academic institution. Are you okay with this routine that we typically do? So again, focus on transparency and involving patients in decision-making about what is being done to their bodies. Next slide, please. Centering the patient. So a large theme was the idea of patient choice and autonomy. Anytime you get to choose anything, in abortion in particular, I think we've found that it increases patient satisfaction, makes women feel more empowered. But I think it's just another way that we're potentially empowering people to be able to make some sort of decision about their procedure. And again, this focus on transparency and fostering trust, I thought it was really good, because I think it was something that obviously some patients are rightfully very anxious about, meaning the examination under anesthesia, and especially given our patient population at the University of Chicago in particular, and the history of medicine exploiting Black and brown bodies. I thought that was really good that it was something that was explicit. It just helps create a greater culture of transparency about what their medical care is going to be. Next slide, please. The role of learners. Again, participants were in the role of teachers, but they, of course, were learners at one time themselves. So one respondent reported, I was excited about it because honestly, I feel like as a medical student myself, felt uncomfortable at times doing exams under anesthesia, with it being a little not well defined to the patient as who exactly would be doing what. Like obviously there were never any exams done that weren't indicated, but I think that for women, it's really important that they know what's happening to their body. And involving students, I think that the patient just felt more comfortable with the known entity if I consented them in general to just a more general idea of what a medical student was. Next slide, please. And this is a very similar theme. Next slide, please. So some conclusions. I think it's very clear that obtaining explicit consent for examination under anesthesia with learners engenders trust with patients, supports autonomy and respects bodily integrity from just strictly thinking about core principles of clinical medical ethics. My data that we've collected demonstrates that nearly 90% of patients accept pelvic examinations under anesthesia with learners. Obtaining explicit consent for this examination is not burdensome, and it fosters a more transparent and supportive learning environment. So my conclusion is there's really no excuse not to obtain consent for pelvic examination under anesthesia with learners. Thank you very much. These are my partners with my research and clinical work.
There we go. Thank you. Thank you so much, Dr. Chor. One of the themes that we keep hearing about is that people won't do it if they're asked. And thank you for responding to that. Yes,
yeah, that's kind of the whole point, isn't it?
Right.
That's the whole point.
That just won't happen. So thank you. Dr. Caplan, do you have anything you want to respond to that or speak to? Nope.
Every time I get on this thing, the phone rings. That was a great talk. Thank you, Dr. Chor. And I wonder, do you have any reservations that somehow your sample of willingness to do this is skewed because of where you surveyed or where you looked, or are you pretty confident that you could generalize?
I think that the patients that we care for, given the sensitive nature of the care they were seeking, some of our patients come to us with any sort of pregnancy complications, seeking care for highly desired pregnancies that have, again, medical or fetal problems. These are procedures where patients are thinking a lot about their decision making. It's a very sensitive time. And so if anything, I would anticipate perhaps that fewer patients seeking the care that we were providing might be interested in having extra people involved. But again, that's something that would have to be examined, looking at different populations.
And then my other question is, has ACOG, the American College of Obstetricians and Gynecologists, or other professional groups, have they taken a position here?
So the American College is very clear as to their statement that explicit consent should be involved for pelvic examinations under anesthesia with learners solely for the purpose of educating the learner. And so that's quite clear.
So that lets me add one other point, Lucy.
Yeah.
When you have a standard set by the guiding group, there could be liability if someone were to really say, you did this exam without my permission. Now, I don't think it would attract lawyers because there's usually not much harm here, physical, and that's what tends to bring them in. But the principle is established that this is expected morally. So jumping to get it done legislatively isn't that big a jump.
Thank you. Thank you very much. That's a good point, and one we will use, I'm sure. We do have we have several questions here. One is thanks for the presentation. Did you speak to providers about the best way to implement changes related to consent? At what level of the individual providers or institutional policies or state laws or things like that? Is there sort of how would we talk about it?
Yeah, this was very much at the level of kind of the department slash residency and fellow training. And so we did ask for questions of how the introduction of such practices could be best implemented, but not necessarily about how to change things at a higher level. So that wasn't something that was explicitly asked in these interviews.
Thank you. And the question is it a common practice for more than one student to perform these exams on a patient?
I would say in my experience, it's not a common practice. I'm not saying it doesn't happen, but I would say that's not a common practice.
We've heard differently, but that's good.
Well, I mean, I think you hear,
right,
you of course are going to hear stories of people lining up to do examinations. That has not been my experience. Dr. Caplan also referred to health educators. Certainly when we're introducing how to do a pelvic examination in like first and second year medical school, we have health educators who are trained experts to educate medical students on how to perform these examinations. And so they willingly teach the students using their own anatomy how to do these examinations. But in the operating room, my personal experience has not been that, this kind of worst case scenario of having like a long line of students to do an exam. I just, that's not something that I've seen.
Great. I apologize, I just have to. So here, what's the best practice do you recommend for obtaining consent given the different power dynamics at play between patients and the providers? Because I think this is really the crux of the issue, right?
Yeah. I think it can go there. I think we have yet to determine kind of the best way to do this, right? Some of the participants in my research have said that it's nice to have the student who may be involved in that examination be present in the room with that discussion so that the patient has an idea of who would be participating. Others felt that having that student there could be coercive or put more pressure on the patient. So I think we still have to kind of figure out the best way to do it. And honestly, that's going to change from patient to patient. But I think that the key component is having a very honest and transparent discussion of, we have students involved in all aspects of our care and our training. And one opportunity for them to learn the pelvic anatomy is to do a pelvic examination under anesthesia. We obviously would not do this without your permission. Let's have a conversation about that. And, is this something that might be of interest to you? What might be some concerns? So just having a back and forth conversation about this.
Just two comments about what not to do in consent. One is, don't obtain consent to the exam as you're being wheeled in for your procedure. So that happens a lot. People sometimes get asked, are you okay with an episiotomy on the way to the delivery? Are you okay with a C-section? The time to ask is when the person is in the room and they can listen and decide what they want to do, not on the way to something where you get consented on the gurney, which sadly you see sometimes. The other is you got to give them a minute to think about it. So this is a standard informed consent problem. I come in the room and I say, would you be willing to be someone who participates in teaching for purposes of training the next generation of students. There will be no injury, there's no real risk involved to you. It's a demonstration. Check this box now. And you want to give the person a little bit of time to think about maybe a minute, 2 minutes, something, ask a question, that sort of thing. So a good informed consent will always be done in a situation where the person doesn't feel coerced, like on the way to the procedure, and where they feel like they have a minute to ask a question or think about it.
And I would say one final piece is also stressing to the patient that their care will not be compromised should they not want a learner involved. That's really important. And, again, being in a learning institution, a teaching institution, there is inherent, there's hierarchy, there are power differentials. And so patients are already feeling this pressure. And so I think it's incumbent on us to really very explicitly say to the patient that this is not, their care will not be changed, whether or not they decide to agree to having a learner involved in this aspect of their.
And as Lucy said, it'll vary according to the person and the culture. There are cultures that don't want anything but women to examine women. They're more conservative about who can see what and for what purpose. So you need to be sensitive to those differences as well.
Yeah, it's as I said before too, evolving, right? It's as we all move forward. So a question here was, is it typically the OB department that conducts these exams, or can it be in other surgeries, and and who's included in this, I guess?
Yeah, so again, my area of expertise is gynecology, and most pelvic examinations under anesthesia will be performed by gynecologists. Urologists may perform these examinations, but intimate exams extend to other examinations as well. It could be rectal examination. So it's not strictly gynecologic examinations. There certainly are stories of people going in for some sort of abdominal surgery, liver surgery, where, the patient undergoes a pelvic examination that has absolutely nothing to do with the surgery that they're going into the operating room for. I really think that those are outliers. I've never personally heard or seen of anything like that happening. So the vast majority of pelvic examinations are certainly going to be performed by obstetrician gynecologists in the operating room.
Yeah, I've seen a little bit of training of the forensic people too. So learning how to deal with sexual assault, they have to learn how to take the samples and examine for tears and all this other sort of thing. So that's another setting where training has to occur.
So just with my knowledge of Connecticut and Safes and Sanes, the nurses that do the forensic evidence collection, is that models are hired for that in Connecticut.
Health educators.
Yeah, and it's all the training is done through the Office of Victim Services in Connecticut. So.
By the way, in case people don't know, there's a lot of settings now where we are hiring models and patient educators, not just about this, but about, how to have a conversation about bad diagnoses or how to get consent to an advance directive, or it's a growing area. It's a little more expensive. I'm not denying that, but it's not hugely expensive. Even in Connecticut, there's an abundance of unemployed actors.
Well, there you go. So, I do think that is something that people don't really realize, that there are people who will be models and act as models. And so there is an alternative for those who don't want to do it, perhaps on a patient. So we just have a couple minutes. I didn't know if either of you had something you wanted to say to wrap up, or we could take another question. What?
I think we could take another question.
So I have just one underlining thought. The biggest challenge of COVID has been trust. anything we
Yeah.
can do to build trust will help us, not just in OBGYN or even in teaching hospitals, but it will help us with the public. And I hope if we get this bill through in Connecticut, that we write some op-eds about it, that we draw it to public attention. It's a way, and I hope legislators talk about it in their districts. It's a way to say we are trying to secure trust. And that has been really a lubricant in short supply, I can tell you, throughout COVID.
Yeah. And I would just like to let everyone know too, that there is a active group of us who are working, and one particular person who has written, I think, every legislator probably 10 times over the last 4 years to get this bill passed. And he has been sort of the wind behind our sails. So it's interesting because he worked for a pharmaceutical company and he always had to get explicit consent for anything he did. And this is just amazing to him. So I do want to thank you both. This has been really interesting. And thank you for your research, Dr. Chor, because I think that will make a big difference. That is something that I've heard, as I said, people won't do it. And I think, well, yeah, okay, that's a reason to ask there.
It's kind of the research to demonstrate what I knew was true.
Right.
So,
well, thank you, because we know working with scientists, you need the research, right? That's the thing. And listening to an advocate is not necessarily, they want to see the numbers. So thank you so much for doing that. And Dr. Caplan, thank you. I have your 7 points down so clearly. That was just fabulous. You may see some of that in my testimony as well when the hearing comes around. Thank you. And I would like everybody to know that if we will be posting information on our social media about the bill. You can sign up for our newsletter where we'll be sending out information as well, or just contact me. I think we have a slide that's up while we're closing out, so that has my email address on it, and my phone number. So if you want to contact me, that would be great. So thank you both so very, very much. I just so appreciate it. This was just a fabulous hour. Thank you.
thank you very much.